Dr. Richardson yesterday about the OPTIMISMM study. This compared pomalidomide, bortezomib, dexamethasone to the control arm of bortezomib, dexamethasone alone. Amrita, what did you think of that presentation? Will it change your practice, or was it kind of expected?
Well, it was expected, but maybe it will change my practice a little bit more than I expected it to as well.
Okay.
So, I mean,
why is that?
So 60% of the patients did have prior bortezomib. Obviously, actually were about 6% that were bortezomib refractory, but I exclude those and really look at the other ones who had prior exposure. So, I mean, the patient you described, right, RVD, transplant, len maintenance, you could actually consider POM, Velcade, Dex for that group of patients. They should do fairly well, and it's a well-tolerated regimen. So
I think one of the keys I took away from the presentation was that they enrolled a lot of Revlimid refractory patients. Is that your understanding too?
2/3.
And Sagar, what does that influence your? Does it make you feel more comfortable using pomalidomide as opposed to a non-IMiD regimen?
Yeah, I think it sort of now gives us another alternative with phase 3 data as a POM-based salvage regimen. And I think not only does it sort of give credence to PVD, but I think it also gives credence to the idea of POM plus ICSA, as Amrita's shown, as another alternative for an all-oral salvage regimen.
And also, I think what's probably unique about this study is the movement of POM to earlier lines of therapy, right? So if you're practicing on label, particularly ex-US, it's not given in first relapse. And so here, first relapse was allowed. So I think it shows that as POM moves earlier, you do see the better mileage from the drug.
There's also something very comfortable for the patients to just switch from lenalidomide to pomalidomide. It's just taking another pill, and they usually can
Are you convinced that you can rescue lenalidomide refractory patients with pomalidomide alone, or do you need to use triplet therapy? And if so, what's the contribution of pomalidomide there?
I think you can. I think the durability of that response is much better in a triplet than it is with just POM-Dex alone.
And what's the biologic rationale for that? You've got the same class of drugs targeting the same protein. Why do you think going from one to the other would be an effective strategy?
Well, I think there are differences in potency and binding affinities. I think your lab has actually shown differences in what the downstream effects of len versus POM versus now CC220 and other compounds in that same category are. So there are probably subtle differences between the drugs.
And it works. You know, in clinical practice, we've done this, and we've seen patients who've had nice responses.
Fair enough.
I was really surprised. I'm wondering what you guys think. In the Rev refractory population, the PFS was actually only 9 months. And that's actually a theme from almost all the studies that were presented yesterday, that the PFS, and when somebody becomes len refractory, is actually typically less than a year.
Okay, but in first relapse, it was 20. Well, I don't know.
Well, that was
but
first
for
relapse. But if you just
OPTIMISMM,
took the len refractory patients, the PFS was 9 months. And then Ajai presented data too with carfilzomib and daratumumab in the len refractory, and the PFS, that was the best. It was 14 months. But once you become len refractory, your PFS actually is not so good. It's actually really, I think, obviously a bad prognostic marker, even with pomalidomide and bortezomib, et cetera.
Well, if you're throwing out one of your major drug classes, that it becomes difficult. I mean, one of the things I took away was that if you're going to use these triplet regimens, it should be at first relapse, because the 20-month PFS for the triplet was, I thought,
Yes,
quite
it
impressive.
was very nice.